Happy Wednesday. Good afternoon. Thank you, everybody, for joining us for today's third Cowboy Conversation hosted by OSU Center for Health Sciences Alumni Association and OSU Foundation. My name is Lauren Sparks, and I am the program coordinator for OSU Center for Rural Health. I'm going to present our presenters to kick off our third Cowboy Conversation. We have joining us today Dr. Mark Woodring. He is the Lawrence L. and Georgia I. Dresser Chair of Rural Health Policy, the AT&T Professor of Telemedicine, and Assistant Dean for Rural Health. As the STORM Club Advisor and teaching the Rural and Underserved Populations course each fall semester. For our second year medical students, Mark enjoys creating shared learning and research opportunities for OSU students, faculty, and rural medical communities. The OSU Center for Health Sciences is comprised of diverse faculty and staff at the State Office of Rural Health, AHEC, Telehealth, Global Health, and the OSU Rural Health Policy and Research Center, created in 2002 in partnership with the state of Oklahoma. Prior to OSU, Dr. Woodring spent 20 years as the hospital CEO and senior executive with the Kansas Department of Health and Environment, leading various healthcare finance and policy initiatives for the largest branch of Kansas state government. Dr. Woodring received his BS in Risk Management and Insurance from Bradley University, his MHA from University of Iowa, and Dr. PH from University of North Carolina, Chapel Hill. We also have Dr. Crystal Von Felt, 2020 OSU-CHS Alumni Association Endowed Professorship in Rural Medicine recipient. In her role as the Endowed Professorship, Dr. Von Felt expresses how spending time with medical students has made me a better physician, and the eagerness to learn has kept me up to date on the ever-changing pulse of medicine. They remind me why I began this journey. Dr. Von Felt serves as the physician of family medicine and OB at Duncan Regional Hospital. She also serves as the OSU COM didactic preceptor and hospitalist at Healthcare Consultants. She is an OSU COM alumni who graduated with honors in May 2011 with her concentration in rural health. She also completed her residency at Integris Great Plains Family Medicine from 2011 to 2014. In her free time, Dr. Von Felt enjoys spending time with family, physical fitness, and gardening. I'd like to start off the program by discussing the why behind why you serve or desire to serve rural communities. Dr. Woodring and Dr. Von Felt.
Great. Well, thanks, Lauren. Appreciate the kind introduction. And how much time do I have to talk about all the great things at OSU Rural Health and the why of what we do? I tell you, super exciting time. First, I want to thank certainly the Alumni Association and CHS, Bria, Annie, the foundation, for all their support. We have an amazing team here at CHS and our Center for Rural Health. Super excited about the future. Maybe I'll start by saying how I usually end some of our conversations, where I get to see the future of rural healthcare in Oklahoma every day. And it's just so exciting. You see the students and their passion for rural health. It really gets to the roots of why our College of Osteopathic Medicine and Center for Health Sciences exist. We have amazing faculty. We've got great students and staff all working to help improve rural healthcare in Oklahoma. And our students, we're continuing to attract those students that have that same passion and energy that we do. From our perspective, we're laser focused on helping return rural students to their communities as physicians and as healthcare leaders and providers in their community. So we're partnering with 4-H, as many of you know. We're partnering with FFA through the Blue Coat to White Coat program. We're partnering with Project Orange. We're working with our STORM Club and our medicine students on adopting elementary schools to help teach and guide mentorship in early ages on the importance of health and well-being. You look at our 3+1 program that continues to attract students throughout Oklahoma that is geared towards returning those students to their rural communities and practicing as physicians. Our rural medical track, getting to partner with our rural medical education team and clinical education. On RMT, we've probably experienced year-over-year growth of about 50% from last year's class. Last year, we were around 12, 13 students. This year, we're around 18, 19 students. We fully expect another 50% year-over-year growth this coming class, where we expect to have 25 or more students. I think the Tahlequah campus, in partnership with Cherokee Nation, not only helps us recruit those rural medical track students, but also supplemental tribal medical track program that also will return students to tribal communities to practice. So super excited. And I will bounce the ball to Dr. Von Felt, who is actually one of our first rural medical track students. So Dr. Von Felt, welcome.
Thank you. Thank you. Yes. So I did have the privilege of being kind of one of the first part of one of the first classes as they started the rural medicine track with Dr. Pettit. And I really enjoyed it. It really kind of fueled my interest in rural medicine. I love rural medicine. I practice and live in my community every day. I live here in Duncan. What first drew me to rural medicine was just the idea of how I can practice. So traditionally, family medicine and primary care doctors practice a pretty broad spectrum in rural communities. And I knew I wanted to do OB with family medicine. And I knew that I wanted to do hospital medicine. So I wanted that traditional structure of when my patients are in the hospital, I take care of them. And I take care of OB and peds. And so rural medicine really is that perfect structure for that. There are a lot of phenomenal primary care doctors in rural Oklahoma still practicing in that manner. And I love it. It's very fulfilling and still do that. I've been here about, I think, 7 years now. And for me, rural medicine was not only about how I can practice, but the people that I'm helping. And from the very beginning of medical school, a lot of education was given to students about, the great need for more physicians in rural Oklahoma and the discrepancy of healthcare that they have, and the goal of OSU to provide better health to our rural communities. And being the majority of Oklahoma is rural, it improves the health of Oklahoma altogether. And so really from day one, that was sort of implemented. This is important. This is a need, and we need physicians there. And in being part of the rural track, it was really just a great start for me. And I knew I wanted to do that. I also learned about Physician Manpower Training Corps, which helps get physicians into rural communities by loan repayment programs. So, got set up and started with that too. And then by the time I started my first year of residency, I had already signed and was ready to come to Duncan. So I love it here. I love the people that I care for. I love being invested in a part of the community. I love being at my kids' soccer game and seeing children that I delivered playing. And so I just love being a part of the community here. And so it's been a wonderful experience for me being a part of OSU and partnering with OSU this year and getting to hear stories of students that Mark and I were just talking about after their month of rural rotation. What that has meant and their experiences has been exciting. And I enjoy sharing my personal experience and learning how their experiences were. So it's been a great ride so far.
And really great learning a bit more about why.
Yeah.
Rural health is so important to our state, and I think it would be great to learn a few top projects you're currently working on.
Sure. Well, thanks, Lauren. And I'm excited to hear more about some of the work Dr. Von Felt is doing in her community too, amidst the pandemic and their COVID clinic and the impact that she's having. We're just so blessed to have her partnership and collaboration as our alumni professor this year and this season. From the Center for Rural Health perspective, I'll say, speaking of the pandemic, we probably were one of the first in the state to take the state data in terms of COVID cases that were positive and put that on a map. That's on our website, it's on our blog. You can find that. And from a healthcare infrastructure perspective, we were able to track, the differences in communities with the COVID and how it was passing through their community. Every community responded a little bit differently, and you can see that in the rates. And over time, we could see that the mortality data was different for rural communities versus urban communities. We're one of the first to also then crosswalk that to vaccine uptake. So we're taking state data, we're putting that out there to the community and sharing what communities may be still struggling in terms of vaccines. So we know from a hesitancy perspective, that's something that we're studying with our rural evaluation and research team and faculty. We also know from the State Office of Rural Health perspective, amidst the pandemic, we were out there leading the way. So appreciate our team in Oklahoma City, partnering with about 50 to 60 rural hospitals in our state, on Incident Command Center and getting ready to deploy and communicate their community needs to the state and getting them ready for the pandemic. They also helped acquire and deploy ventilators that were needed in their communities. So really appreciate the partnership and collaboration we have with our state office of rural health. From a research perspective, telemedicine, we appreciate the partnership with AT&T, who's allowed us to do some innovative research. I think the deployment of carts, telemedicine carts into rural communities during the pandemic was interesting. We're still learning a little bit more about that. Some of the communities have used them as a virtual hospice program, where basically that is their now model for care for inpatients. Some of them have used the carts primarily for just relief. Maybe that's weekend call or other needs. So the use of telemedicine is interesting because last year we think about the rural and underserved focus class, and our students weren't exactly sure how they might adopt telemedicine in their future practice. This past season, a majority of our students recognized the value that telemedicine could have. Even though we're a high-touch school of medicine, how do we incorporate high-tech needs? So we're still working on that, but I think communities are evolving and recognizing there is some value in telemedicine. We've partnered with the Extension Office in Stillwater on some great educational programming and opportunities for overcoming health disparities in some of our markets that face persistent poverty and have different healthcare needs and issues to help achieve health equity. Because at the end of the day, that's really what our health center is built on, the idea that we're going to help achieve health equity for all of rural Oklahoma in all of our state. So we're partnering in a project called Tier 1, which is with our friends in Stillwater. Vice President Sewell and all the deans and President Shrum really applaud their innovation on this approach. We were one of the first to really participate in university-wide collaborations with faculty. So I'm working with our team in Stillwater on rural renewal, which is a way where we're combining how do you study youth development and at-risk youth with telemedicine deployment, with the need for broadband expansion. How do you use white space, TV white space, to expand access? So multidisciplinary research in a focused place-based Tillman County and in Harmon County, which are two of our most persistently impoverished counties in Oklahoma that face population decline as well. So a lot of headwinds. As a land-grant university, how do we partner with one another from a research perspective to help add value to the community process, strategic planning, and working together to overcome these things? Alongside of that, obviously, is the student research piece, which we're really excited about and can talk a little bit more later. So that's, in a nutshell, some of the work that we're doing in our center.
Okay, so I think now would be kind of a good time to sort of just share my experience in rural community and how we dealt with the pandemic. You know, we have a pretty good network of physicians that communicate well together here in Duncan. And we came together, you know, when this all started hitting and, you know, the governor was giving recommendations and there was a lot more questions than there were answers. And we didn't have a lot of answers for our patients. You know, we came together and decided that in efforts to try to, how do we help patients who need to come to the doctor who aren't infectious sick, but still need to come in and be seen for their heart failure, their diabetes, their COPD, other medical problems was one of our goals. And then how do we keep people from overrunning our ER for COVID testing, and how do we keep those people safe as they're coming in? We were also in the middle of an ER remodel in the middle of all this. So it was pretty hectic. We came together and decided, you know, we worked really well together and decided what we would do is create one sick clinic. And that would allow the other clinics to relatively be safer so that patients coming in for heart failure don't get exposed to COVID while they're there. And so my clinic, by the nature of how it was built and that I also take care of COVID patients in the hospital, became the COVID clinic in Duncan. And so we are all a part of the same electronic medical record. So my patients who were not sick were diverted to two of the other clinics in town for routine visits. And we're told that this is temporary and that you'll eventually be back with your doctor. And then on this other side, the other clinics who had sick patients were diverted over to us for the COVID clinic. And we did the majority of our testing by car testing, which we still do now. So our clinic was pretty much set up entirely from car clinics, and we did quite a bit of testing. That also allowed people to come get tested without bombarding the emergency room. And it was very successful. We did that for quite some time. And then a few months ago, once everyone became prepared and we had enough PPE for the other clinics, then we kind of dispersed and went back to a setting where sick patients were outside and seen and well patients were inside and seen. From a hospital setting, we made a list of doctors who had ventilator privileges. We were really lucky enough to have a pulmonologist who just started, Dr. Michael Hemphill. So we had a list of people who could take care of ventilated patients in the ICU, and then those who could take care of regular med-surg patients. We had doctors who had sort of retired from the hospital side who only did clinic, who came back to got re-credentialed to take care of non-COVID patients. And so I think we reached a peak of about 46 active COVID patients in the hospital at one time, and our hospital beds are approximately, I think, 110 beds. When we separated them, we have 2 floors and an ICU. So our ICU was completely full of COVID, and then we had a floor full of COVID, and then we had the non-COVID floor. So it's definitely been an interesting situation. We definitely used a lot of telemedicine, as Mark alluded to. I was already familiar with telemedicine graduating from OSU, and they've kind of been, leading the medical field in that in Oklahoma. And so that concept was not new to me, but I had not implemented it in my own practice until then. And so it really did work very nice for patients who didn't need to come in. We also used our home health agencies to go do vital signs and lab work if we needed it from home. So some of those really at-risk patients could get their care at home. So that was sort of our pandemic, COVID project over 2020. And so now the major focus is education on vaccinations and talking with patients. We do some seminars through our DRH foundation with several physicians educating and putting out on a Facebook Live information. I think that patients do well when they listen to their providers from their community that they trust, because there's a lot of misunderstanding out there in social media. And these patients have been home and on social media, and and as they are coming out and starting to do their regular visits, talking with them one-on-one. And usually when I'm able to talk with them, then they feel a lot better about getting their vaccine and get signed up to get vaccinated. So, I think it just comes with that patient-doctor relationship and trust, and okay, I feel better about that, and we'll do that. And as we are seeing, vaccination rates go up, we're seeing COVID go down. And of course, as the warmer weather is helping us too, but we're still actively trying to get everyone vaccinated. And, I know from my personal standpoint, when everything was getting very crazy and we were hearing, other states, especially up north, having a hard time and sort of seeing as it was coming closer and closer to our state, and what are we going to do to keep our patients in our state healthy? For me, it was really nice to see Dr. Shroom up with the COVID task force, a face that I knew and trusted, and to know that OSU partnered with the state to help with rapid testing and testing results and what they did for our state, which is super impressive. And I was very proud of that and felt comfortable knowing that we were in good hands. And, as our testing got better, then, we had more answers for patients. And so it was a long year. Things are getting better. We have more answers. But I think the most important thing is that we all work together. I'm pretty proud of how that went. So,
thank you both. Those are all great whys. It was wonderful to hear about some of the priorities that focus on serving our rural communities. I'd love to hear about what your ideal future of rural health society looks like. Could you share us what you hope to see in the future for our rural communities?
Great question. And as mentioned earlier, the future of rural healthcare in Oklahoma is bright. I mean, it is an exciting time to be a part of it. I know there's 12 persistent poverty counties specifically in our state. A persistent poverty county is one that has 20% or more of the population that's been in poverty for more than 30 years. It's measured by the U.S. Department of Agriculture. So we know that some rural medical communities may be not able to sustain their traditional model, whether that be the hospital-centric model. We've been advocating for change with former Secretary Benj. He's our Executive Director of Tribal and Rural Health Policy. There's a new model of care coming out in 2023 called Rural Emergency Hospital Status. It's very similar to critical access hospital status, whereas it would allow an inpatient hospital to close the inpatient, but still maintain emergency room coverage and outpatient coverage and expand on telehealth. So how do we not only study the change, but how do we help facilitate and lead maybe change from our center in some of these communities, recognizing we have to meet them where they're at. And the needs of every rural medical community are different. So it really takes active listening and engagement. For example, Secretary Benj and I went out to Tillman County as part of our Tier 1 initiative, met with some of the state legislators, some of the local community leaders, as their hospital had closed in Frederick in 2016. That results in the next nearest emergency room for many residents out there of about 45 minutes. So think about that golden hour that people talk about in terms of response to emergency needs. It may take 15 to 20 minutes before you even get the volunteer crew to the site, whether that be a motor vehicle accident or somebody's home. And then it takes 40 minutes to get to the next nearest emergency room, not taking into account the actual treatment time that maybe have to take place. So we had a conversation. We said, well, we can't necessarily build you an emergency room right now. We know there's a new model of care that may be coming out that we're advocating for. But in the meantime, how about we hook up our ambulance out here in Tillman County to our emergency room out in the OSU Medical Center in Tulsa. So with just a push of a button, a Zoom tablet in the back of their ambulance can connect in real time to a physician. So if there's any question, whether that be a volunteer EMT or paramedic, they'll have an opportunity to have a physician basically alongside them, helping along that path to the nearest emergency room if any questions or concerns may come up. We've been studying the connectivity of broadband, making sure that the video and the audio capability is strong enough to be able to have a good virtual consult. We'll have more results here coming out later this year, but we're excited about that and the impact that could have in terms of rural emergency medicine throughout the state and throughout the country, as there's only a couple places here in the U.S. that are piloting this type of an approach right now. So we're really appreciative of that. And we think that this type of opportunity wouldn't have happened not only without the engagement of our policymakers and our leaders at CHS, it doesn't happen without our medical students. We were able to have rural scholars participate in the deployment of this project last year and to spend a summer just really engaging and learning with the EMTs and paramedics, which is great for their learning. And I think that helps recruit future rural medical track students. So we really believe that a lot of the student research and initiatives that we're working on together do crosswalk into other things that we're looking to do and achieve. And it's a partnership with our state and with our faculty and our staff and center and our students. Couldn't do it without them. A couple other quick things that I've got here, and I'll bounce the ball to Dr. Von Felt. Speaking of our students, last year for class, we had them all adopt a county in Oklahoma and basically perform a community health needs assessment, very similar to what we do with our state office of rural health for our hospital communities. And they were able to come up with a plan for change and recommendations on how they would help improve the health status of their population. We know that sometimes in a physician office, we can only take care of one patient at a time, but we know that through community health leadership and population health initiatives, we're also focusing on how we take care of whole populations. So it gave some great value experience for our students. And then some of those ideas we're sharing with the counties for them to deploy. So there's a lot more work to be done. We appreciate the partnership with again, faculty and staff and our students on that. The center continues to partner with the Institute of Healthcare Improvement out in Boston. It's one of the most progressive, forward-thinking healthcare performance improvement systems that are out there in the nation. Former CMS Administrator Don Berwick, Dr. Berwick leads that charge, and we've been able to incorporate some of that curriculum into our rural medical track. So again, it's creating leadership pipelines for medical students to help achieve health equity and population health. We couldn't do that without IHI and the leadership support of, again, all of our alumni and foundation to make those types of partnerships happen. But we're really, like I said, not just studying the change, but we're helping lead the change. And we know there's opportunities for us to move forward, and it's just so exciting. So that's the future as I see it. Lauren, thanks for asking.
I think that's a great question. What I see and want for our rural communities is for them to have the same health care provided to them as someone in Oklahoma City. So just as Mark said, the timing of certain things, if we have a farmer in South Oklahoma who has a heart attack, I want them to have the same, mortality risk as someone who has it in downtown Oklahoma City. And there's a lot of big change that has occurred in the last few years, and I'm so excited to hear what OSU has done and all their innovative changes and understanding the true need for that, and what our rural communities are dealing with. And I feel like they really are getting into the underlying issues and finding real answers for our patients. And I think that we will start to see life expectancy, mortality, morbidity changing in our rural population. So I don't want living in a rural community to be a health risk factor for somebody. I want them to be able to live anywhere they are in Oklahoma and get the same level of health care. And I think it starts with our students, and seeing them in their rural clinics go out and experience what healthcare is like in a rural community. And even our students who are from rural communities going back and thinking from a medicine lens, what that's like for each patient. And one of the things that we ask them to do is to go over resources. They pick a case, they pick a patient, and they do research about what resources are in that community that can help the patient. And so there are a lot of great resources, but as they are seeing in their investigation, there's not enough. And so, getting more healthcare, more options for patients in rural communities. And I think we're working on that. We're heading in the right direction. I'm excited to see what our future will be.
Future continues to look bright for OSU-CHS and for our rural communities. We still have so much work to do, but it sounds like we are definitely headed in the right direction and have the right people on the front lines serving our communities. Thank you, Dr. Woodring and Dr. Von Pelt. I greatly appreciate you taking time out of your busy schedules to visit with us today. We have Cowboy conversations scheduled throughout the year. Please be sure to check out our website to stay up to date on future events. And thank you all for joining us today. Have a great week.